A 59-year-old lady presented with pyrexia and right upper quadrant pain 2 days following her elective laparoscopic cholecystectomy. On review of her operative notes, her operation was noted to be uneventful. Outline the management of this patient.
The key aspects of my management would include initial resuscitation, including the sepsis 6, followed by urgent imaging. This includes administering intravenous fluids, adequate oxygenation, opiate analgesia, and requesting blood tests including liver function, inflammatory markers, and culture and sensitivity. I would order an urgent CT scan of her abdomen. I would consider starting her on antibiotics in the light of the results of these tests.
Okay. The CT scan shows a large collection in the subhepatic space. How will you proceed?
The large nature of this collection suggests that it is unlikely to be due to irrigation used in her surgery. Due to the localized nature of this large collection, I will arrange a percutaneous drain of a suspected biliary collection by interventional radiology and then closely monitor the patient's condition as well as the drain output over the next few days. If the drain output continues to be significant, I will request an ERCP.
All right. If bile is seen coming through the drain, what are the different possible sources, and how would you manage each situation?
Residual bile at the time of surgery is a possible source and is managed by the drain alone. Ongoing bile leakage from a cystic stump leak or the accessory duct of Luska would be best managed by ERCP and stenting. The stent is usually left for 4 to 6 weeks, and certainly after the drain output has stopped. At this stage, the drain may be removed if the patient was clinically well. Bile from bile duct injury requires urgent repair by a hepatobiliary surgeon, either in the form of primary repair with or without a T-tube, or hepaticojejunostomy with a Roux-en-Y loop, depending on the extent of the injury.
Does an MRCP have any role in assessment of patients with bile leak?
In the presence of ongoing bile leak following IR drainage, an MRCP can be useful in determining if there is any evidence of bile duct injury and the extent of such injury. It is also useful in diagnosing any significant residual collections. It could be utilized in serial imaging after 4 to 6 weeks of drain insertion and ERCP stent placement to ensure that the bile collection has resolved, and thus it is safe to remove the drain.
All right. What actions would you undertake if you suspect a bile leak from an inadvertent damage to the bile duct intraoperatively?
I would stop the dissection, perform a washout, and place 2 large drains in the vicinity of the leak. I will then urgently communicate with a hepatobiliary surgeon. There is an option to perform an intraoperative cholangiogram if the cystic duct stump is accessible, and it is safe to do so. I will send the images to the HPB team.